Okay, the next speaker is Arupratan Maiti. He's from Kolkata, and he's going to talk about right heart assessment of right ventricle. Little difficult topic. I'm sure he'll do a good job.
So in the recent past, the echocardiography was LV-centric and RV was regarded as a forgotten ventricle and a younger brother of the LV as a less important member of the contractile apparatus. But the practice has changed recently, and why there is a shift in the practice? Because the RV function has independent association with clinical outcome and prognosis. So if you search the web, you will see hundreds of publications which states that RV function is very important for clinical outcome and for prognosis of the patients. So it's very important. And obviously, we have got very sophisticated technology and software which enables us to assess the RV more efficiently. I had to put some statements now before I start my core topic. The current echocardiography guidelines for quantification of RV are based on transthoracic echo, not TE, although all the parameters can be assessed by TE. In digit states, RV shifts from its predominant longitudinal contractility pattern to a different one, and RV ejects the same stroke volume as LV, but stroke work is 1/4 of the RV. So RV contracts in 3 modes, like inward bellow-like motion of RV free wall towards the septum, shortening of the longitudinal fibers pulling the apex towards the base, which creates the predominant RV cardiac output, and through traction of septum by LV towards the RV cavity or septal bulging, which accounts for 20 to 40% of the cardiac output. But why RV measurement is difficult? Because of its non-geometric, asymmetric crescent shape, and compared to LV, the RV structure is quite complex, and the inflow and outflow cannot be visualized in a single plane in 2D echo. And secondly, the septum is shared by the LV, plenty of trabeculations and endocardial border delineation is difficult. RWMA of RV is very difficult to detect, being a volume pumping chamber and being affected with afterload and being a very anterior portion of the chest, it limits the visualization in echocardiography. So the different views have already been discussed today. Now coming to the core topic. So what findings can be expected in 2D or 3D in a case of RV dysfunction? So if you look at this RV and the walls, you can see fair longitudinal contractility, fair free wall contractility, and some septal contribution. And the RV size is small, it's normal. So this is the RV, normal looking RV. So now compare with the 4 types of RV. If you see this RV, there is some longitudinal movement, but no free wall movement, not much of septal movement. So this is quite dysfunctional RV. If you look at this RV, there is some free wall movement, but no longitudinal and septal movement. And if you look at this postpartum cardiomyopathy RV, the size is normal, but not much from anything. But this RV, if you look at this, the RV is quite dilated, looks like it's volume overload, and some contribution to the from the septum and from the free wall. And obviously, you can use 3D to for a better assessment of the RV contractility. Explain is a very good mode to look at different angles from different planes, and short axis view obviously gives you idea about the contractility of the RV along with the size. You can compare the size to the LV. So RVOT contraction is very important. So RVOT contraction you can view in a mid-cervical RV inflow outflow view. You have to see the RV contractility, whether it's dilated. Dilated RVOT is a very important hallmark in a case of arrhythmogenic right ventricular cardiomyopathy. In case of very severe RV dysfunction, you can expect some smoke in the RA can be rarely seen, and you can also see stagnation in the IV, smoke in the IVC. And obviously, with severe dysfunction, you can expect some SBC dilatation and not much of movement of the SBC, and obviously IVC and hepatic vein all get engorged in severely dysfunctional RV. The pulmonary artery can get dilated, and so is the right atrium and tricuspid annulus in some of the cases. If you look at the atrial septum here, so in case of severe RV dysfunction, sometimes the atrial septum will be bowed down to the left side, and you can see a PF flow crossing right to left. So right to left shunt across the PFO. The coronary sinus can get dilated in long-standing RV dysfunction. You can expect varying degree of severity of the tricuspid regurgitation, and obviously tricuspid annulus gets engorged, as I told you before. So now coming to the RV dilatation. So how to understand that RV is dilated? So if you compare the size of the RV with the LV, you have to see whether the apex is formed of the RV. If the apex is formed of the RV, that means the RV is dilated. And if the area of the RV is more than the LV area, that means RV is dilated. Obviously, there are some numbers to denote that. I'll come to that later. And RV hypertrophy best measured at inferior or posterior wall of the RV at endostole. If this is more than 5 millimeter, then RV is hypertrophic. In case of severe RV hypertrophy, like in severe pulmonary, it's more than 10 millimeter. So there are a couple of videos. First thing is the RV overload. If you see, the RV is quite dilated, and predominantly the septum is in bulge during the diastole. And if you look at this RV, the septum is bulged at the end systole and early diastole, and the RV size is not that big. So this is pressure overload. Now, once you have found some RV dysfunction, then need to see the causes for RV dysfunction. So causes, you can see severe mitral stenosis. You can find some clots in the pulmonary artery, pulmonary thromboembolism. There may be pericardial collection collapsing the RV, or you can see severe mitral regurgitation, any form of cardiomyopathy, and arrhythmogenic right ventricular cardiomyopathy. This is the transthoracic images where there is massive trabeculations, and there is a moderator band becomes very prominent, and also the amyloid heart where the septum becomes very thick. So measurements of RV systolic function, RA volume and RV volume, hemodynamic calculations, and RV diastolic function. So I'm going to discuss these things next. These are the indices of the RV systolic function. So two-dimensional fractional area change. This is the marker of global RV systolic function. 2DFS less than 35% implies RV dysfunction. It measures both longitudinal and radial component. It correlates very well with CMR. It can predict outcome, and it has got established prognostic value. And most importantly, it is preserved after pericardiotomy. So it's a valid parameter after coronary cardiopulmonary bypass, after cardiac surgery. But it neglects the RVOT contribution, and be cautious while you are doing this, and exclude the trabeculations while measuring this. 2D RV ejection fraction, it excludes the RVOT contribution. It is load dependent. Prognostic value is not established and is not a method of choice. So anything less than 45% is abnormal for RV. Tissue velocity at the lateral annulus, or S prime, it gives us the longitudinal RV systolic performance globally, and is not a marker of contractility. Reference value available for pediatric population, which is less than 11.5 centimeter per second, abnormal. It is angle dependent, load dependent, and it can be affected by the tethering effect of the stunt myocardium. Anything less than 10 centimeter per second implies the RV is dysfunctional. Coming to the tricuspid annular plane systolic excursion, it measures the RV longitudinal function, good correlation with radionucleotide-derived ejection fraction. It has got established prognostic value, but problems are it is angle and load dependent, does not take septum or RV into RVOT into contribution, invalid if RWMA present, like in RV infarction, not preserved after pericardiotomy, and caution in pediatric patients with volume load and single ventricle. So TAPS less than 16, anything less than 16 will be abnormal. So next is the Rvot fractional shortening. So this is the parameter to measure the contribution of the Rvot. You basically take the M mode and take the diameter in diastole and systole. Anything between 61 plus minus 13% is normal Rvot. RV-DPDT is a simple technique with sound physiological basis, but it is load dependent, less accurate in severe tear, not recommended for routine uses. Anything less than 400 millimeter mercury per second is abnormal. So DPDT, if you see this formula, 15 millimeter mercury, if you take 0.5 to 2, but if you take from 1 to 2, then it comes 12. Next is right index of myocardial performance, or T index. So this is the index of global RV function. It gives us idea both about systolic and diastolic function. Good thing is this is independent of heart rate, preload, afterload, and AV valve regurgitation. It has got established prognostic value after heart transplant, and it's falsely low in rise in RA pressure, and it's not valid for in arrhythmia or AV block. So you can do it by pulse wave Doppler, where you need a similar RR interval and normal values are less than 0.43 or 0.44, and tissue Doppler normal value is less than 0.55. And strain. So strain, it can be done either by 2D strain or 3D strain. This is angle dependent, independent. It can overcome the tethering effect, which is seen in the S prime measurement. It is used for RV function in pulmonary artery hypertension. RVAT, TOF, correlates very well with ejection fraction by MRI. Reduction of RV strain and increased intraventricular dysynchrony are associated with pulmonary arterial hypertension. RV strain is a prognostic marker for mortality in COVID. In COVID situation, we are seeing a lot of RV dysfunction, and RV strain has got established prognostication for in these cases. But this is load dependent, and one important thing I am to talk about strain is that more accurate RV function in mechanically ventilated patients by TE than transthoracic echo. So these are the reference value of the RV strain. And now coming to the measurements of the RV and RA, we need to take some basal diameter, mid diameter, and length of the RV, RA area, and RA diameters and RVOT diameters. RV diameters more than 42 at base and more than 35 at mid-level indicates dilatation. Longitudinal dimension more than 86 indicates enlargement. RA area anything more than 18 centimeters square is abnormal. RA length more than 53 as major, and RA diameter more than 44 at end diastole indicate RA enlargement, and RVOT diameters more than 33 and 27. So 3D echo quantification of the right ventricle. So we have got a new software called the 3D Auto RV. So it combines the proven Tomtech with Philips machine learning, artificial intelligence, and eventually gives us the final result with end diastolic volume, end systolic volume, stroke volume, and ejection fraction. So everything is done automatically. It calculates and tracks the speckles automatically, but there is option to change it if you need to correct. Hemodynamic calculations of the RV. So we need to take right ventricular systolic pressure from a tear jet. Pulmonary capillary wedge pressure we can get from Nogue formula, but this E by E prime is from LV. And we also can get pulmonary artery mean pressure from the early PI velocity and pulmonary artery diastolic pressure from the late pulmonary regurgitation velocity. RV cardiac output we can get like in the conventional formula, area of the RV 0.7 diameter into by VTI RVOT, and pulmonary vascular resistance can be calculated using this formula. So yeah, if that is more than 0.27, that means PV is more than 14 OT, it's high. If this is less than 0.2, p-value is less than 10 would say unit. RV diastolic dysfunction RV diastolic function can be obtained by PWD at tricuspid inflow or TDI at lateral tricuspid annulus or pulse wave Doppler of hepatic vein. May not be valid in severe TR. In heart failure patients, the RV diastolic function is frequently abnormal and is associated with difficult separation from the cardiopulmonary bypass. So tricuspid E by A less than 0.8 suggests impaired relaxation, E by A between 0.8 to 2.1 with E by E prime more than 6, or diastolic flow predominant suggests pseudonormal, tricuspid E by A more than 2.1 with a deceleration time less than 120 suggests restrictive filling. There is some normal value of the EOF and AOF. So what are the cardiomyopathies which affect the right ventricle? First is the arrhythmogenic right ventricular hypertrophy. In this case, you will typically see a dilated or right ventricle, prominent right ventricular outflow dilatation, which is a hallmark feature, prominent trabeculations, and prominent moderator band. Obviously, the ejection fractions will be very low. Non-compaction cardiomyopathy, though predominantly it affects the left ventricle, but less than half of the cases, it can affect the right ventricle as well, with increase in trabeculation and recesses. Hypereosinophilic syndrome is a RV cardiomyopathy which mainly affects the RV apex with scarring of the apex and thrombus formation. Amyloid cardiomyopathy can affect both LV and RV. The RV becomes quite hypertrophic, particularly the intra-atrial septum thickening is a hallmark of amyloid cardiomyopathy, and you can see a speckle kind of appearance, toric eye appearance in these cases. And hemochromatosis can cause global dilatation of the RV and severe RV systolic dysfunction, causing ascites and hepatic congestion. But peripatetic cardiomyopathy, anthracycline toxicity, DCM, everything else can affect RV. We have seen cases. So my conclusions are fractional area change found to have correlated with MRI-derived ejection fraction of RV and a very robust parameter. Post-pericardiectomy, not all methods can be used with reliability, particularly TAPSE. Assessment of RV diastolic function should be included in routine echo, particularly when diastolic dysfunction can precede systolic dysfunction, as in cases of pulmonary arterial hypertension. RV strain has good correlation between transthoracic echo and transesophageal echo. 3D RV assessment is best wherever available. These are my references. Thank you very much.